About 20 years ago, a director of nursing from a mental health trust contacted me while I was at the Tavistock and asked if I could help with a problem. The problem was that the clinical culture carriers, who were sort of squeezed between managerial pressures on the one hand and clinical pressures on the other, were losing their capacity to think about nuance and subtle communication, whether that's from staff or from patients, and were being pushed into a position where they were either reacting to actions that were done to them, or they were becoming rather mechanical in their responses. And we designed a course that we thought might help the clinical managers deal with these pressures and think about, how to keep up their capacity to think imaginatively about the problems they were faced with. Joe, what about
Yes,
your experiences? Yeah.
yes, sure. I got involved in this course a few years ago. At that time, I was a ward manager as part of leadership development for ward managers and team leaders in my trust. At the time, there was a critical need for this development because, ward managers and team leaders were transitioning from clinical roles to managerial ones. And just as you've mentioned, they were facing, or we were facing at the time, and I think still happens to this day, numerous competing demands. So there was a need for some staff development. So we were in a better position to deal with situations that will come across daily as team leaders and managers.
And perhaps we can start with you, Marcus.
Well, when a patient is admitted into the mental health system, they're often in a fragmented state of mind. And what they're requiring from the mental health system is a place where they can be looked after and cared for, but also understood. The regressed state of mind that goes along with the fragmentation can sometimes mean that they're very reliant on old scripts, often based on early experiences. And this can lead to frustrations between staff and patients as they're misunderstanding one another. So, for example, someone who's been neglected or mistreated may bring those attitudes towards mental health staff, making the staff feel like they're doing a bad job. One of the things that we can help with is to sort of provide a lens in which we're thinking about how those scripts have come about and how they play out in the here and now of the current situation. That can deepen our understanding of the patient and what they're dealing with, and also help the staff to tune in to what the patient's struggling with. Joe?
Yeah, so I would hope participants would gain a deeper understanding of the patient's experience, as I did, and also improve therapeutic relationships. So, for example, I was involved in a focus group or a project recently on outstanding care, and I was part of a survey where we interviewed staff and patients at different times. And one thing that they both wanted was to spend more time with each other. So then we needed to know or understand what was preventing this. So that was the question. And patients did report that, when they had spent time building relationships with the staff, some more patients come in or new patients come in who are more agitated and then tend to disrupt the ward and hinder any progress that had been made. And also, in addition to that, we know patients do not spend as much time, that's needed to build these relationships with staff on the ward. So I believe that what this course can help staff do, or staff will take away when they attend the course, is to make the most effective use of the limited time that they do spend with their patients. And I think from a psychoanalytical perspective, it can help achieve that.
Well, just in response to what you were saying, Joe, that sort of complaint that staff aren't spending enough time with the patients has been around for as long as I've been in psychiatry, which is a very long time. One of the things I think about is the fact that often patients are communicating in ways which staff can't tune into. So sometimes they're expressing themselves through their actions or maybe psychotic communications. And I think that it's important that a psychoanalytic approach can help put a lens on the way that the individual's trying to communicate to staff about their difficulties, which might not be through ordinary language and what we might think of as symbolic thought, but more through concrete action and symptoms.
Yes, of course. I'd like to share an experience years ago. I was a ward manager on female acute wards. We had patients who were admitted with a diagnosis of emotionally unstable personality disorder, and they did exhibit behaviors that challenge, and the patients tended to be with us for quite a few months. So some of these behaviors were what we call splitting, so splitting the team, self-harming behaviors as well. So a few of those that really did stay with me and stay with the team. When I say with me, is trying to manage staff and anxiety and emotions. Was, the staff felt very, very confused and difficult to understand how patients remained in hospital, didn't want to be discharged, but then, just didn't feel that staff were doing anything right, or patients, self-harming, for example, tying ligatures, but then pressing the alarm and then continuously doing that. So staff felt very frustrated by that, helpless and ill-equipped to manage these presentations.
It's a very familiar picture dealing with EUPD, isn't it? Where you've got this confusion between the patient doing very destructive things to themselves, but also not wanting help, and then sometimes wanting help, and staff don't know how to understand it. Often the staff teams get split between quite a judgmental position, this patient's not ill, needs to be discharged, and a rather sympathetic position in which they're the victim of circumstances. In a way, what needs to happen is you need to bring together these different elements of the patient, that it's an internal conflict between something very judgmental inside themselves and on the one hand, and then some part that feels quite weak and unwanted. The staff team needs to come together in the first instance before you can talk to the patient about a sort of conflict that they're struggling to manage, and that you could support them with bringing these different aspects of themselves together in a more helpful way. People in clinical positions, mental health nurses, psychiatrists, psychologists, occupational therapists, social workers, but also importantly managers, because clinical managers are the culture carriers of their teams. And we think that this course can be very helpful for them in managing the interface between management and being a clinical leader.